So thank you for joining me live. I appreciate that it's a very tricky time of day, 7 o'clock, but hopefully you have somebody to help out with the kids. So yeah, tonight we're going to be talking about beyond the diagnosis, rethinking ARFID through a holistic lens. I was on full screen. There we go. So this is me. I'm Lisa. You may already be familiar with me, but I'm a pediatric naturopath. I'm also a nutritionist and a feeding therapist. And I founded this business, the Pediatric Naturopath, which also trades as the Pediatric Nutritionist, because I'm just so passionate about kids' health. So in the team, we look after children with eating issues, eczema, gut issues, allergies, the whole thing. Um, and I I hate to put this sort of statement at the front of any presentation, but I just want to say that there's a lot of other practitioners who have signed up for this webinar tonight, which is wonderful. But I just want to make it clear that I'm here to educate and share, but this content is not to be copied, reproduced, or used commercially without permission. So please don't screenshot, record, or repurpose this material as your own. As I say, I hate to say these things, but it has to be said. So the first thing is you are not failing your child. If meal times in your house are stressful, exhausting, emotional, it doesn't mean that you've done something wrong. So I work with families every day who are doing their absolute best to feed their children. So this isn't about blame or, pointing the finger at anybody. It's about really trying to understand what is going on beneath the surface for your child. That's what we're all about. And I really love it when people ask questions as I go along. It makes me feel like I'm talking to people rather than just talking to myself. So as we go along, if you have a question, just you can either unmute yourself and ask the question. That's totally fine. I'll leave pauses for that. Or you can type it into the chat box. Either is fine. So what we're trying to do when we're trying to help kids with ARFID is we're trying to make your child feel better and make their body work better because ARFID isn't distinct from your child. It's a reflection of how they're feeling and what's going on beneath the surface. So we're trying to make your child feel better. So I love this picture of a cat, and I don't know if you've seen this on TikTok or whatever, but it's the cat like being exposed to different foods and just dry retching and gagging when it sees the food. It's funny because it's a cat. Obviously not funny when it's your own child. And I remembered when I started to do the fussy eating work, working with a child, and I could not believe his guttural reaction when he saw something as innocuous as like a piece of ham or a piece of cheese. Even from a distance, he would be dry retching. And I'm like, wow, I've read about this, but I never realized it's possible. So this is a cute cat who is gagging. But if this sounds familiar to you, then you're in the right place tonight. So meal times are very tense, very emotional. Your child's just eating the same foods over and over and over. If you expose them to new food, then they'll panic, gag, like this little kitty, or just shut down. You might have been told that they'll grow out of it. You've probably got a very limited list of what you might call safe foods. I don't like that term, but I know it's a very widely used term, safe foods. There might be very strong reactions just to the smell or temperature. And in the end, you just avoid eating out and social situations because of the drama. So, of all the hundreds of children that I have helped, I have not ever come across a child where the reason that they weren't eating well was because they were just stubborn. And a lot of people will come to me and say, my child's just stubborn. Honestly, it's never the reason. There's always something else. It's not manipulation. It's not caused by poor boundaries because you will often see within the one family that there's one child with ARFID and one child that eats a wide range of foods. And it's definitely not a lack of effort because the frustration in parents that I talk to that they're just cooking the dino nuggets night after night after night, it's definitely not a lack of effort on their part. So I work with ARFID every day. I see this impact on the kids and on the parents, but also I get very frustrated with the misunderstandings around ARFID. It's underdiagnosed and also overdiagnosed at the same time. Oops. Um, so it often flies under the radar. The earlier you get in and start to address it, the easier it is to address it. When I see kids come to see me when they're 2 or 3, it's so easy because they play with, like they play. That's their job. They just play. So playing with food and helping them to expand their repertoire is actually quite easy and works really well. Much, much harder with 9-year-olds, 10-year-olds. So, and the problem is people will go see a doctor or a pediatrician and they'll say their child's not eating well, and they'll just be told they'll grow out of it, something random like that. And that's really harmful because that prevents early intervention. There's a big crossover between autism and ARFID. So about 20% of children with an autism diagnosis will also have ARFID. But again, we're trying to look at what's happening underneath the surface. We're trying to understand your child's body, but also their nervous system. And we're never trying to force food. We're trying to support your child because there's nothing going to be worse for somebody's nervous system than being forced to eat something that they don't want to eat. So the agenda for tonight is going to be what is ARFID, but also PFD, pediatric feeding disorder, which is not talked about anywhere near enough. We're going to talk about why it's important to address because I get the sense often that, well, there's a sense of hopelessness with ARFID, that there's nothing that can be done. And it it is very hard to treat, but it must be treated. And I'm going to go through some of the reasons why that is so. I'm going to talk a lot about the gut-brain connection because that's really what sets us as nutritionists and naturopaths apart from occupational therapists or speech therapists that will often work with children with ARFID. I'll talk about the types of ARFID, how we treat. I'm going to give you 5 changes that you can walk away with tonight and start to implement into your lives. I'm going to explain how we work, and then there'll be plenty of time for questions at the end. So you can either ask questions as you go or at the end, up to you. So by the end of the day, you'll have a better understanding of what's happening and what you can do about it. So what is ARFID, or AFRID, as people often call it? So it's avoidant restrictive food intake disorder. And it was introduced into the DSM-5, which is kind of the Bible of mental health disorders, in 2013, which is not that long ago. It's 13 years ago. And now it's in the same category as anorexia and bulimia. So it's defined as a mental health issue. And so that's the medical term. And to be honest, it's not that helpful in the actual term. It's more about what's happening for your child than this label. And this is from the DSM-5, and this is what the criteria are for an ARFID diagnosis. So you can see it's a feeding or an eating disturbance, yeah. So it can be either significant weight loss, which is not that common, significant nutritional deficiency, which is very common, dependent on enteral feeding or oral nutritional supplements. So kids that are on like a pre-made formula like Pediasure, marked interference with psychosocial functioning. It's not because there isn't enough food at home or for some cultural reasons. That's not why kids aren't eating. It's not because children are worried about their body shape. If it's a body image issue, then it's anorexia or bulimia, not ARFID. But this is really, really important. This point number D, where I have the big red arrow. The eating disturbance is not attributable to a concurrent medical condition or better explained by another mental disorder. When the eating disturbance occurs in the context of another condition or disorder, the severity of the eating disturbance exceeds that routinely associated with the condition. So basically, you have to make sure that there's not something else going on. If there is something else going on, it's not ARFID. And So ARFID is not just fussy eating. It's very distressing and affects every aspect of daily life. But it needs to be distinguished from pediatric feeding disorder, which I'll talk about in the next slide. And when I look in Facebook groups, when someone says, "Oh, my child's a very fussy eater," blah, 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 everybody say, "I think it's ARFID," and they'll post like a million links. It's ARFID, it's ARFID, it's ARFID. I think that's it's incorrect, basically, because not all those children have ARFID. Some of them do, but just my child is a fussy eater does not equal my child has ARFID. And it's very, very, very important not to label a child who's a fussy eater as having ARFID without doing the due diligence, because ARFID is a mental health disorder. And if there's a physical reason that's actually stopping a child to eat that can be addressed, it should be. So this is a very helpful chart from, it's a website in the US called Feeding Matters, and it's basically an advocacy group for children with eating issues. And you can see they've pulled apart the difference between ARFID and PFD, pediatric feeding disorder. So ARFID is primarily mental health. Pediatric feeding disorder is multidisciplinary. Both pediatrics and comorbidities for ARFID, mental health disorders, especially anxiety, and for PFD, any medical or development disability. So what they haven't kind of elucidated here is that PFD can be due to a lack of skill, which is like oral motor skills, the ability to chew, all those sorts of things. And if your child can't chew their food, therefore they're not eating, that's PFD, that's not ARFID. So you need to be sure that it's ARFID. And this research paper that was done quite a few years ago now, it actually looked at 422 children who had been referred to the hospital for treatment for ARFID. So they'd been given a diagnosis of ARFID. So they went through the 422 children, and actually only 294 of them met the criteria. So those 1, 2, 3, 4 criteria that we just went through. Then they applied the exclusion criteria. So that is the exclusion criteria is there can't be any other health issue which is causing the problem. And then only 133 of the original 422 actually qualified for an ARFID diagnosis. The others had the other medical issues, so reflux, constipation, diarrhea, food allergies, food intolerances, and other issues. So you can see all these children were giving an ARFID diagnosis, but the due diligence had not been done. So before an ARFID diagnosis is given, this is what should happen. So there should be a medical assessment of the growth, eating history, and nutritional status, investigation of the underlying physical drivers like gut issues, immune, inflammatory, nutritional assessment more than just weighing. There is nothing less helpful to know if it's ARFID or not than weighing a child. Absolutely useless. It has no bearing. Needs to be a mental health assessment. There needs to be an oral motor and swallowing assessment. Has the child actually got dysphagia where they can't swallow properly? Have they got a tongue tie where they can't actually move their tongue to eat the food? All of those things need to be assessed. Assessed for sensory processing issues and actually observing meal times at home and parent-child dynamics. So, if the child is always having to eat on their own at 5 o'clock, and the other members of the family are running around going about their business, and that child's not eating well, then that's, going to be the problem, not ARFID. So that's the direct observation bit. And I know I am laboring this point, but I think it's really, really not talked about. So these are the differential diagnoses that need to be looked at before an ARFID diagnosis. So do they actually have anorexia or bulimia? Do they have anxiety, OCD, reflux, eosinophilic esophagitis, which is pretty common in kids with ARFID diagnosis, inflammatory bowel disease, celiac disease, pica, so like eating non-food items, allergies. Like there's a lot of things that need to be ruled out before you can say that it is ARFID. So any questions on that sort of introductory, is it ARFID session? Just, I see a few more people have joined us, which is wonderful. If you miss me saying it, you can either just unmute yourself now and talk, or you can type it into the chat. There we go. What if restricted eating is what is causing constipation? Absolutely. We're going to talk a lot about that later on, about that vicious cycle. So, yeah, definitely. And there are ways around it that don't involve food changes initially. But if you can address the constipation, then your child will eat better. So I'm not telling you all of these things now to like create any mother guilt with anybody, but I do think it's important to talk about the reasons why this is important and why you need to help your child expand their diet. So scurvy is back, which is not surprising because if your child's not eating any fruits or vegetables, they will have no vitamin C. So scurvy is back. Um, this is just, types of food avoided and what sort of the consequences are. And you can see with, B12 is only found in animal products, so meat, egg, dairy. When you're low in B12, you've got mouth and tongue discomfort, not going to help you eat. You've got low energy, constipation, anorexia, and that just means lack of appetite. So not anorexia nervosa, just lack of appetite. So actually, not eating meat and being deficient in B12 will reduce your appetite and make it sore to eat. So giving a B12 supplement is a great way around that. And testing your B12 levels first would be even better. Bone health is very important. I do a lot of hair tissue mineral analysis because a lot of kids with ARFID have anxiety. A lot of kids with anxiety don't necessarily want to go for a blood test. So we use hair samples to do that initial screening for nutrient deficiencies. And everything should be around this grayed out line down the middle of the page. And you can see this girl, 7-year-old with ARFID, and she was very deficient in everything. And her brother kicked her hand and it smashed to smithereens. This is not her x-rays, this is from a paper, because she was just so nutrient deficient. And so this paper just looks at, the evidence suggests that children with autism and ARFID are at elevated risk for fractures. Wernicke encephalopathy, which is thiamine deficiency, so one of the B vitamins, will cause mental confusion like psychosis. So again, if your child's not eating foods that contain thiamine, they could end up with psychosis and then be put on risperidone. So the gut-brain connection, this is where it'll get super fun. One more question. Tell me how you can assess hair analysis for nutritional deficiency. It would be a lifesaver. Oh, and your question is it may not be available in our regional area. So we do, I'm going to say about 1,000 hair tissue mineral analysis every year in our practice. Nearly every single kid we do. So your child needs to have clean hair, so not sweaty, not greasy, washed, dried hair. You take a little sample from the nape of their neck and we send you the form and the envelope. We email them to you, you print them out and you make a little envelope and you post it to Sydney. So we do all of this via telehealth. You don't need to come in. We don't need to cut the hair. You do it all yourself and you post it to Sydney just in a normal envelope. Takes about 3 weeks to come back. The cost is $231, so it's very reasonable. And it shows a lot more than just nutrients too. It shows heavy metals. All right, the gut-brain connection. I do have a few busy slides, but just bear with me. Busy slide number 1. I guess I'm just trying to demonstrate that everything I'm telling you is directly from the research, because pushback that I get a lot from other professions is that naturopathy is not based on research. There's no evidence for what naturopaths say, and of course there is. So I've summarized this on the next page, but you can see in a restricted diet, there's more processed food, more sugar, there's less fiber, there's less protein. And there's a bi-directional pathway from your gut to your brain. So evidence suggests that the microbiota gut-brain axis plays a pathophysiological role in the onset and maintenance of symptoms of ARFID. A restricted diet promotes specialized microbiota, depleting microbial diversity, yada, yada, yada. So this is what I've tried to summarize in words. So what happens in ARFID? There's limited food variety, so your gut microbiome diversity reduces. That means there's fewer good bacteria in your gut, which means there's less short-chain fatty acids in your gut. There are less B vitamins, K vitamins, tryptophan, which we convert to serotonin. More processed carbs and sugar leads to inflammation. Why this matters? So the changes in the gut might make children feel full too quickly, have a low interest or enjoyment in food, have sensory sensitivity and disgust, fear-based eating, anxiety, mood issues, and rigid thinking. So ARFID may be maintained by a feedback loop between restricted eating, gut health, and brain signals, meaning that the gut is a legitimate treatment target, not just behavior. So again, if you go down the sort of the standard path with ARFID and go to an OT or a speech, they're not looking at the gut, and starting with your gut health is actually definitely one of the options that you have. So of course, we would love to do that through food, but there's other gut supportive strategies. And my favorite is really prebiotics and probiotics, because those are white, tasteless powders that you can easily get into children. They feed up the good bacteria, they starve out the bad bacteria, they give a little boost of the bacteria that help with your mental health. And yeah, that's and it reduces constipation. So prebiotics like partially hydrolyzed guar gum, which again, just a white powder, can go into anything, will reduce constipation. Once you reduce constipation, your child's appetite will start to return. They'll start to be able to eat more fruit. They'll be less constipated. This is another paper talking about the same sort of things, but this is interesting because it's saying that um, children with ARFID don't eat dairy, and that's a problem. But I find that cheese and yogurt are actually some of the preferred foods. What's up to move? So basically, these dietary patterns increase the risk of nutritional deficiencies. And another very busy slide. So dysbiosis, so that just means your gut bacteria are out of balance. Reflux, constipation, medications cause discomfort. And for a nonverbal child with this discomfort, they will express it with vocal cues, motor behaviors, aggressive behaviors, and sleep disturbances. So, when a child comes in with self-injurious behaviors, they're usually in pain, and that's why they're, hurting themselves. So disruptions in these pathways here with the immune system and the microbial metabolites, disruptions in these pathways cause neuroinflammation, altered neurotransmitter levels. So neurotransmitters are things like serotonin, your happy neurotransmitter. Again, more busy slides. In children with ARFID, they've got more of these bacteria. So Bacteroides vulgaris, Enterobacteriaceae, and they've got less of the bifidos. If you remember one thing about gut health from this, bifidobacteria are your happy bacteria. More bifido, more happiness. So whatever we can do with prebiotics and probiotics to increase bifidobacteria in your child's gut, the happier they will be and the more they will want to try new food. And again, just more stuff to say that what is happening in your gut will affect your food preferences. Another really good example of this is candida in kids. If they've got an overgrowth of candida in their gut, which is caused by having too much sugar and too much refined carbohydrates, that will control their appetite and their desires for food to be desiring more of the sweet food. So addressing the candida will help to expand their repertoire. So in summary, look at gut health along with everything else. This is about teenagers with reflux, constipation, stomach pain. We'll also have ARFID. And this is a bit different because this is talking about allergies. So one of the big risk factors for having ARFID is having allergies. And you can see, and whenever you've got a child with allergies, you kind of do impart anxiety onto them about certain foods, which then makes them kind of more nervous. But it's, you know, children with allergies are going to be more nervous about foods. And if that goes too far, then they can develop ARFID as a result. So I'm going to talk about the types of ARFID. So can be broken down into three categories. So dietary restriction due to sensory sensitivity, fear of aversive consequences like choking or vomiting, and a lack of interest due to poor appetite. And you can fit into, multiple categories. So we'll start with the first one, which dietary restriction secondary to sensory sensitivity. I would question whether this is not actually pediatric feeding disorder instead of ARFID. And really, that makes it a feeding disorder, not an eating disorder. Because remember, ARFID is in the DSM as an eating disorder, whereas PFD is a feeding disorder, which can be treated by, treating the sensory issues. So this is where occupational therapists do a lot of their work is around sensory issues, but we also know that zinc, fish oil, vitamin D are also really important for sensory regulation. So if your child has ARFID secondary to sensory sensitivity, I would say that might actually be PFD, and you need to work on the sensory side of things and treat the ARFID like that. Fear of aversive consequences while eating. So fear of vomiting or choking. So this could also be several things. This could be something called pandas, which I'm sure some of you have heard of because there's a big crossover between ARFID and PANS. So PANS is pediatric acute onset neuropsychiatric syndrome. PANDAS is when that is associated with a strep infection. But one of the key characteristics of that is kids just stop eating. And it comes on overnight, like 19th of February, my child stopped eating. That's probably PANS. And if we treat the PANS through whatever way we decide, it could be antibiotics for some children, it could be, antiviral herbs for other children, it just depends, then the ARFID goes away. Another thing that I get very concerned is being missed is eosinophilic esophagitis, and that's where you get inflammation in your esophagus. So it literally hurts to eat. So why would you want to sit down and eat dinner if it hurts? That has to be diagnosed by an endoscopy. But once you know that that's why they're scared to eat, then you can treat that. Some children will have other chewing or swallowing issues, so they don't feel like the food is going down smoothly. So if we look for these issues and treat those issues, again, is it really ARFID? And are we looking hard enough for these confounding factors? So someone has just asked for the sensory sensitivities. Did I say zinc, fish oil, and vitamin D? It was vitamin E. So zinc, fish oil, and vitamin E. And then lack of interest in in eating secondary to poor appetite. So number one, constipation. Get your child pooing every day, whatever way you can. And my favorite way is partially hydrolyzed guar gum. Number two is a zinc deficiency. So zinc is found in animal products, same as the B12 I mentioned. If your child's not eating animal products, I guarantee they have a zinc deficiency, which will suppress their appetite. If they're also not eating animal products, they're probably iron deficient, so that will also decrease their appetite. I see a lot of kids on ADHD medication, side effect being they have a very poor appetite. And then worms. People always say, oh, my child eats like a horse, they must have worms. It's actually the opposite. Whenever your child has worms, it decreases their appetite. I have podcasts, webinars, everything about worms. So if you know that worms are a problem for your child, just have a look at my podcast, Holistic Health for Happy Kids, and I have an episode all about worms. So anxiety, there's a big crossover between ARFID and anxiety. more so than with anorexia and bulimia. So you also could say, well, maybe if we treat the anxiety, the ARFID will go away. And that might mean a medication, but of course, I would prefer to use other things like prebiotics, probiotics, herbs, all those sorts of things. And this is just a chart looking at ARFID, anorexia, and bulimia. 28% of children with ARFID have a generalized anxiety um, disorder compared to like only 14 or only 7 for the others. So big crossover. Also a big crossover with OCD. You can see 6% of kids with ARFID also meet the criteria for OCD. And it is treatable. So as I say, I'm very passionate these children need help. We can't just, write them off as having ARFID and that's it. And this is a really nice research paper, and it looked at a treatment program for ARFID, and it went through, it was all done like remotely, um, went from 1 to 7, looking at things like just psychosocial education on ARFID, treatment goals and concepts, charting accommodation. So one of the big outcomes for this was that whenever you do too much accommodation for your child with ARFID, it really reinforces them not eating well. So, of course, we need our children to eat. And as loving parents, we will do anything to provide the food that they want to eat. But we also need to, you know, be rational for them when they're not being rational themselves about some things. And by going through this 7-part program, over half the children did meet the criteria for ARFID by the end of it, which is amazing, given like it's pretty simple. It's really just talking and education. Um, so in my opinion, there's a big issue with inconsistency across healthcare professionals when it comes to ARFID. And there's underdiagnosis, but there's also overdiagnosis. So it's definitely not just your child being difficult. They're not just trying to control you. They're not just, refusing for the heck of it. It is a stress response, like a fight or flight response for many children. They don't feel safe to eat, so their body just kind of shuts down. And as I say, they lose their logic, they lose their rationality, and you need to be the logic for them. Um, Children will grow perfectly well. Some of my fussiest eaters look fabulous. They're the tallest people in their class. They're going great. And even sometimes blood tests will look pretty normal. And so it'll just get missed and people will just be told it's fine. All kids are fussy. Um, so it's again the three kind of zones are the lack of interest in eating, sensory and fear. And that's what we're going to be talking about now, because if you can identify for your child what pathway they're on from an ARFID point of view, then we know how to treat them better. So sensory and oral motor. So food will feel overwhelming, texture, smell, temperature sensitivity. They'll gag or fatigue with chewing because they're not very good at it, and they'll avoid messy foods. So at home, this is the child that either eats just crunchy foods or just very smooth foods. So like just crackers or just soup. They definitely won't be sitting down and eating a steak, and they won't be eating food where everything's mixed together. They'll be taking a long time to eat because they're not very good at chewing, and they're getting very tired because they're not very good at chewing, and it's a lot of hard work. Plus, being deficient in things like iron and the B vitamins just make your muscle tone quite low, so they actually don't have the strength to eat well. Brand sensitive too, yes. So I see a lot of kids that are very brand sensitive. So kids who will only eat the KFC chicken nuggets. So not the McDonald's chicken nuggets, not the Hungry Jack's chicken nuggets, just the KFC ones. And so logically that those three chicken nuggets are pretty much the same. They're going to be salty, like they're going to be the same. So that's a good example of when you need to stretch your child to eating any chicken nuggets. And that's often people's first homework when they come to see me and they say, my child only eats McDonald's chicken nuggets. The first thing is to try and get them to eat all the chicken nuggets. And I don't mean to do that through tricking them or starving them, but trying to, maybe do a food science experiment home where you buy the two chicken nuggets, you put them down on a piece of paper, you draw with a pencil around them. Ooh, they're the same size. Ooh, they're the same shape. Maybe take photos with your iPhone. Ooh, they're the same color. And try and tap into their logic brain to see if, you know, these are actually really similar. I wonder if they taste the same. They do taste the same. Never try and trick your child. So don't, buy the KFC box and put the McDonald's ones into them and try and trick them, but try and do like a food science experiment with them to try and understand. And then you've expanded their repertoire, you've challenged their sensory system, and your life is a little bit easier because you're not restricted to the same fast food restaurant. So then fear-based. So when eating feels dangerous, they're frightened of choking or vomiting. Food avoidance after illness or trauma, and anxiety increases around meals. So they're not eating at school, they're not eating in public, and they get very distressed. They, just shut down at the dinner table, constant reassurance seeking. And then the third one is the body-based medical one. So when food causes discomfort, reflux, nausea, bloating, constipation, gut pain, inflammation, allergies. So these are the kids who will take a few bites and then they'll say, I'm full. And they've eaten hardly anything. Appetite will change day to day. They'll often be home from school because they've got a sore tummy. And I've bolded this grazing. So kids who graze often have reflux and they're eating enough to take the edge off the pain, but not enough to cause pain. So grazing is bad. Let me just put that down. Grazing is not good for your gut. It's not good for your teeth. It's just not good. So definitely don't just say, I put out a plate of food for my child in the morning and they just eat when they want. That is the worst thing that you could do. And if you know that your child is a grazer, you need to stop that and try and feed more on on the clock. But also they probably have reflux or a gut problem that you need to address. So someone said, this is my daughter. She was diagnosed celiac, so felt sick when she ate all the time. I firmly believe that every child should be tested for celiac disease at 1.5, when they go for their injections, one needle in, one needle out, doesn't really matter. When they're 4, same thing, they're at the doctors, just check everybody for celiac disease. In this case, it did cause sort of, I guess, low level gut issues, but often there's no gut issues. Sometimes the issues are teeth, hair loss, like random things. So if your child is a restrictive eater, go and get them checked for celiac disease. We pick it up so much because nobody else has gone looking for this. So another question, is 4 or 5 meals a day too much? No, that's perfect. So to me, for most primary school age children, you want to have breakfast, lunch, dinner, then morning tea and afternoon tea. So if you eat like that, there will be about 2.5 or 3 hours between each food, which is not a long time. Everybody can survive that. But that's very different to when I look at people's food diaries. Sometimes people are eating 10 times a day, like literally every hour they're having something. And it might be great food. It might be an apple at 9, a banana at 10, a yogurt at 11. But it's slowing down your child's gut motility and it's causing problems in their gut and in their teeth. Plus, they're never actually hungry for a meal. Um, and yeah, when I talk about these 3 different sort of pathways, some kids will tick all the boxes and they'll have all of these things. Um, so you want to have a think about what pathway your child fits into. And of course, if your child has ARFID and someone gives you the advice that they will eat when they're hungry, don't give in, they won't starve, it's just a phase. They actually will starve. If they actually have ARFID, they will actually starve and you will end up in hospital if you try to do that. So that will work for typical fussy eating. not letting them starve, but, putting in more rigor will often work for normal fussy eating if they're just a bit, hesitant about food, but they don't have a nervous system dysregulation, but not if they actually have ARFID. Um, Another really good reason why the observation of meal times is an important step in the ARFID diagnosis is because often parents are actually just putting too much pressure on their child to eat, and often not even parents, but grandparents who are heavily involved or force feeding, just putting way too much pressure. And I also see a big crossover between kids with pathological demand avoidance and ARFID. And in that case, even if a parent's not pressuring them at all, they perceive it as pressure. So you need to be very careful about what you say and how you act. Because think about when you've been really, really stressed, maybe somebody died or, something really terrible happened. And you just, well, a lot of people just stop eating because the stress just shuts down your appetite. You're just not interested anymore. You're in survival mode. So when you're stuck in fight or flight, you are not going to sit down to meat and three veg. So forcing a child to eat is definitely not a good thing. And you can't reward them out of this. Like you can't, rewards are another form of pressure. So you can't just say, eat, your sausage and I'll give you a lolly. That's bad for a number of reasons, but also it just won't work in this situation. So yes, they won't starve, will delay proper support. It dismisses the real concerns, and it will actually increase anxiety for the whole family. Yeah, I knew you were going to mention PDA. Raises the challenge curve. Yeah. I think I have a good example of a hair test for a PDA kid coming up. So yeah, pressure increases, child becomes more avoidant, meal times become more stressful. So yes, this is another example of a hair test for a child who had an autism diagnosis, PDA. I mean, PDA is not really given as a diagnosis in Australia, but I see plenty of kids who would meet the criteria for it. So you can see this is one section of the hair test where they're putting things in ratios. So the one I'm looking at particularly here is sodium to magnesium. And you can see the ideal range is between 2 and 6, and this child was 36. So this child is stuck in fight or flight. They are frozen. They will be perceiving any sort of suggestion of eating what's in front of them as a threat, as if they're being mugged. So taking a child like this to feeding therapy is not going to be a good use of anyone's time, and it's not going to work. You have to look at their nervous system first and calm that down, and then look at the food work. Um, when we're thinking of, the body first approach, so making sure a child is comfortable, um, we're looking at their gut, their nutrients, inflammation, nervous system, and these are all the things that we might use to help a child. So prebiotics, probiotics, no taste, no flavor. Anti-inflammatory herbs, okay. I'm not going to lie, they do have a flavor, but because we work only with kids, you can see, well, maybe you can't see, but we use a lot of glycetrates for our herbs. So they're not ethanol based, but they're like a sweet syrupy base for our herbs. So they don't actually taste that bad. And so many kids that I see, even the ones on very, very restrictive diet, they'll take anything from a syringe because they're used to taking Panadol and Nurofen. So you just pop the 2 or 3 mils of herbs in syringe and they're happy. We use a lot of gummies, and these are not the supermarket gummies because the supermarket gummies might have like 2 milligrams of zinc and 3 grams of sugar. And most kids are going to need to take 10 of those gummies. So that's, 20, 30 grams of sugar, which is not a good idea. Our gummies have about 25 milligrams of zinc and about 2 grams of sugar. So it's a much better trade-off. And very, very, very few children refuse our gummies. If we think there's allergies and inflammation, We can use vitamin C, which often comes as a nice chewable. Quercetin, okay, also I'm not going to lie, quercetin's a bit funky to take as a supplement, but if your child can swallow capsules, then it comes as capsules. And some of my favorite nervous system supports are just the really basics, sleep. So, making sure your child's getting enough quality sleep, spending time in nature, doing breathing exercises, put the teddy on your belly and see if it can go up and down. So don't discount these things like the sleep, the nature, the breathing, and do these things with your child. Don't single out your child as you need to work on your nervous system. Do these things together as a family. So it won't work if you just do the food exposure. Won't work if you just do the behavior strategies. The body leads and behavior will follow. So progress isn't, what most parents expect. So it's not loads of new foods, bigger portions. All of a sudden, your child's eating like all the other kids. But it is them being happy to come and have a meal with their family at dinner time, not running away, hiding under the table, or causing a fight at dinner time just to get out of eating it. Um, Not panicking, not just spending their whole day on high alert because they know that food is coming. So their appetite will come back quietly. And kids' appetite usually comes back before the variety. So they'll be asking for food, eating a bit more of their preferred foods, less avoidant behaviors, reduced anxiety, taking small little steps like getting curious and wanting to try a food. Um, but it's slow progress and you have to just get on the journey. It's not a straight line. Kids get sick, things happen, they'll have a bad experience, you know, that's just life. So the way that we work is we have a large team at the pediatric naturopath. So we've got naturopaths, we've got nutritionists, we've got one dietitian, and we've got one of our naturopaths is also an oral myofunctional therapist. And she's also an oral health therapist, like a dentist for kids. So, you know, any of those reasons that we talked about, basically, we have somebody in the team who can help. So we look at the medical and nutritional side of things. We're trained in SOS feeding therapy and a few other types of feeding therapy. So we do use those principles. But we do a lot of work around nervous system regulation and parent support. So in terms of supporting step one in the process, supporting the body, we do love to do blood tests, to be honest, because that's the only way to pick up celiac disease. So you can see this was a child with an ARFID diagnosis, raging celiac, probably had been for years. This was another child with ARFID. So when we did a poo test, a microbiome test, he had high levels of intra-aggregative E. coli, which would have been causing gut discomfort. And this is another child whose zinc was at 4 instead of 15. So they would have had no sense of taste. They would have had no appetite. They would have had a lot of sensory issues. We just need to give them zinc. Step 2, support the nervous system. So this sodium to magnesium level here, you can see 0.17. So in the previous one, it was 36. This is 0.17. So this child has gone through fight or flight, and now they've just tanked. They have been under so much pressure for so long, they've just burnt out. And now we need to support their adrenals and get them back up to function properly because this child's just tapped out completely. You can see this picnic on a picnic blanket. This is one of the suggestions I have to reduce stress at meal times. So sometimes the dinner table has become a bit of a battlefield and everybody just thinks, oh my God, like what the hell is going to happen at the table tonight? Who's going to hit who? Who's going to cry? Who's going to vomit? Take food outside to your back garden, to the beach, to the playground, whatever, and spend a while, like a few nights, a few weeks, just eating on a picnic blanket at the park. just to reduce the stress and to try and calm down everybody's nervous system. And this is, I'm sure, not going to be very popular for saying this, but I do not encourage screens as a means to get children to eat because I do not believe that a screen supports a child's nervous system at all. Yes, you can get food into them, but you're not supporting your nervous system and they're not learning how to chew, how to swallow, and how to enjoy food. So it gets food in, but I do not recommend it, to be honest. I know that doesn't make me very popular. Um, Step three is kind of the feeding therapy side of things. So, food chaining, sensory tolerance, gradual exposure. So this child's licking Nutella off a spoon. So yum, Nutella, one of my favorite foods, but he's actually improving his oral motor skills as he does it. Because like he's got chocolate here, chocolate here. So you get him to lick it off a spoon, he's stretching out his tongue and then say, right, lick it off the size of your face. So you're getting him to actually improve his oral motor skills with Nutella. So it's always progress over perfection. Rome was not built in a day. These are the 5 things that you can take home with you tonight and start to do straight away. So, number one, take the pressure off. Stop the force feeding, stop the bribing, stop the just one bite, and stop the reward charts. And you're probably going to say, but they won't eat. But I'm guessing they're not really eating anyway, or you wouldn't be listening to this. So, this is not a strategy that works very well. So, abandon. Protect safe foods. So, food is food. The food that your child is eating is nourishing them and keeping them alive. So, what we don't want is we don't want them to burn out on those foods. So, say your child eats toast, chicken nuggets, and green apples. If we let them eat a chicken nugget, a green apple, and toast every day, day in, day out, I guarantee at some point in the not too distant future, they will get sick of one of those foods and stop eating them. So then you're down from 3 foods to 2 foods. So you need to make sure you don't give them the same food more than once every 48 hours. In the situation I've given you, that's clearly not possible. So what you have to do is you have to change the food every time you give them. So it could be a different brand of chicken nuggets, but that might be too much. It might be just putting the chicken nuggets on a blue plate one day and a pink plate the next. It might be cutting the chicken nuggets in half one day and quarters the next. Might be cutting up the apple one way, leaving it whole the next. You have to change the food slightly to stop them losing those foods. When they lose the food, it's called a food jag. And that is honestly one of the most important things that you can do. Stop the food jagging. Oops. Yes, we burn out on safe foods all the time. And if you don't think about food jagging, then you will never expand the repertoire. But if you think about food jagging, you will very, very slowly start to add new foods and keep them in the diet. Step 3, focus on connection over consumption. So try and make mealtimes fun again. Try and just sit down and have a chat over dinner. Talk about what Bluey did on TV. Talk about if you're going to go to the beach on the weekend. Talk about where you're going to go on holidays. Don't talk about how many bites people have eaten, who's eating fast, who's eating slow. Just have a chat over dinner. Kids who eat meals together as a family have better vocabulary because they're having adult conversations. So step 4 that you can do at home is, again, just watch their body, not their plates. So notice their appetite changing, not whether they're eating more or less. And trust your instincts. You know your child. If you think that there's an underlying issue that your child has, you advocate for them and you make sure that you get help. And we're great at helping with that. I had somebody last week and I said, I think your child has EOE, eosinophilic esophagitis, and I think that's the problem. And I managed to send her off to a pediatrician or gastroenterologist who saw her really quickly and said, yep, that's what it is. And within like 2 weeks, she had a diagnosis. So just push, push, push. Um, if your child is eating a very limited number of foods, you are not overreacting and you're certainly not alone. And there is heaps and heaps of things that we can do to help. So when is it a good idea to get extra support? If you're just losing your mind with the stress, if your food range is shrinking, not expanding, if you're just stuck, and if your family is really suffering through this. So pressure doesn't fix it, support makes a difference. And the diagnosis of ARFID, it names the problem, it tells you what it is, but it doesn't really tell you anything about it, or give you any understanding of it or any idea of what to do next. So the way we like to work with families is we like to do a 12-week program. And 12 weeks is the minimum that you will need to help your child with ARFID. I would be lying if I said just come for 1 or 2 appointments and we'll be grand. Like that's never the way. Even, with in-person feeding therapy, in the first 6 sessions, you do not see progress. By 12, you see heaps of progress, but you just have to stay the course and trust that it's the right one. So in our 12-week program, we do the hair tissue mineral analysis and we do microbiome testing. And then you receive a treatment plan, and it's a realistic treatment plan. We work with you to understand what's going to work for your child. And then we do weekly sessions, which are either on telehealth, or if you're in the Illawarra, face to face, or if you're on the Gold Coast, we can do it face to face as well. And so it's a very comprehensive program, and it's unlike any other treatment models in Australia because we're just got the whole package. We do discovery calls for this program, and if you scan this QR code, that will take you to the booking page. Sarah, one of our feeding therapists, does those discovery calls, so you can book in a time with her and talk about your child and if this is the right idea for you. Our dietitian can receive NDIS funding and also Medicare, and our nutritionists can take NDIS funding, but not Medicare. So there are funding options available. Okay, so someone said, how to get ARFID support into NDIS plan. NDIS guidelines say they don't support eating disorders. So we get around it through our autism anxiety diagnosis. Setting eating related goals didn't work. Yeah, I mean, I'm not an expert, but it has to be a functional impairment. So you have to be able to explain, I guess, the psychosocial side of things, why it's a functional impairment rather than it being a medical problem. But we do see plenty of children who have an ARFID as one of their diagnoses. I mean, that is definitely not the reason why they got NDIS funding, but it would be one of their diagnoses. And with dietitians, there's something called the M10 healthcare plan, and it can also be used. So you don't need NDIS, you don't need diagnosis, I don't think, but you just talk to your GP and say you want an M10 healthcare plan. Doesn't cover the full amount of the sessions, but it's better than your standard dietetics healthcare plan. So I'm happy to stay. We're at 8 o'clock. So if you have to go to bed, go. But if you're happy to stay and chat and ask some questions, I'm more than happy to chat with you. So someone says, I have an 11-year-old and a 17-year-old girl with ARFID. How should I interact differently with each of them? So you're well and truly past the playing with food stage. I would strongly encourage some blood tests at the GP if you can get that across the line. And I would strongly encourage cooking classes as well. So that's one thing that our dietitian and nutritionists actually love doing via telehealth or in person is just doing cooking with the older kids. And it's cooking with a purpose, but without pressure. So we might make a burrito bowl. So, we'll discuss the attributes of the beans and the rice and the coriander, but there's never any, forcing to eat it. So at those age, I would do testing, definitely, more than just what a GP will want to do. You need to add a few extra things and then organize cooking classes with us or with somebody else. Any other questions? Hit me. I was asleep by this time last night, so I'm doing well. I'm sure more if you have questions. No, I'll give it 30 more seconds. Thank you. No, you're welcome. It is definitely a passion of mine to help people with ARFID because I love my food and I think it's a gift to really love your food and enjoy your food. Can we supplement zinc with testing? I assume you mean without testing, but yes. I mean, I've never met a fussy eater who didn't need zinc. And I don't know what age or weight your child is, but you can go up quite high with zinc. Um, we see a lot of naturopaths as clients. And one of the naturopaths that I'm helping at the moment with her child with ARFID was just blown away that something as simple as zinc could make the massive, massive difference it did, not just to eating, but just to mood regulation, sleep, all sort of the mental health side of things. How do you deal with kids who have medication refusal? I've just started sneaking an iron and vitamin D into the food. Um, you need to try a different form. The problem with sneaking supplements or medication into food is that you're highly likely going to lose the food and then you're a step backwards. So I would um, search high and low to find iron. Vitamin D is easy. It's like a drop or a spray, like, you know, that's very easy. Iron is more difficult, but I would do a little bit more investigation about a form that they would enjoy. Does it matter if you don't give zinc gummy every day? Sometimes we forget. Of course, we all forget sometimes, that's fine. With iron, it's actually better to forget every second day and only give it every second day. Zinc, yeah, I mean, as long as they're getting it, most days, it's fine. And if you forget one day, you can give two the next, but give one at breakfast and one at dinner. So split it up. Um, my, whoops, my daughter's menstrual cycle has stopped. Any advice? She has ARFID, is almost 14, had one or two cycles, but now they have stopped. So it's due to several things. So it's due to basically just not enough food. So her body is saying, you're not eating enough to carry a baby, so we're just going to stop your cycle. And it's body fat is too low as well. Weight is too low. Not really so much about having low iron, but it's and a very important part of female health is to have a cycle and to have period. And if you can find an age appropriate way to get that message across to her that her kind of her bone, I mean, she's not going to care about her bone density, but that's, you have to explain that there's long-term consequences to not getting her period. And she needs to eat more to get her period, to have a regular period, to be healthy. There's plenty of books and resources out there, I'm sure, to help her understand that. Also with probiotics, should we just start them too? There's a lot of crap probiotics out on the shelf, and different probiotics are good for different things. So some probiotics are good for reducing like dust mite allergies. Obviously not going to be very useful in this situation. So you need to be a bit more specific. I will tell you one that is a great one. It's called BioGaia Protectus, and it's Lactobacillus reuteri DSM 1738. And it's just available across the counter. Whenever people join our Fuss No More method, we send out a little welcome pack, and that's the probiotic we send because it tastes delicious. It's strawberry chewable, and it's good for reflux. It's good for constipation. It's good for a lot of the issues that we see. It's called BioGaia Protectus. It's Lactobacillus reuteri, DSM 17938 is the actual strain. But if you go into Chemist Warehouse and look for it, you'll find it. All right, lovely. Well, thank you for joining me um, live. It's so nice. And have a lovely evening. I will be uploading this to my YouTube channel and then sharing the link in the coming days. So if you want to share it with anybody, I would really, really appreciate that. Um, but if not, just thanks for coming and turning up live.